From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Welcome to the JAMA Cardiology Author Interviews podcast. I'm your host, Dr. James Udelson. I'm Chief of Cardiology at Tufts Medical Center in Boston and also an Associate Editor of JAMA Cardiology. Today, I'll be speaking with Professor Sanjiv Shah, who's the Stone Endowed Professor of Medicine and the Director of Research at the Bloom Cardiovascular Institute, as well as the Director of the Center for Deep Phenotyping and Precision Therapeutics in the Institute for Augmented Intelligence in Medicine, in the Division of Cardiology and the Department of Medicine at Northwestern Medicine and the Feinberg School of Medicine in Chicago. Welcome, Sanjiv.
Thank you, Dr. Udelson. It's really a pleasure to be here.
Today, we're going to be talking about a paper being published in JAMA Cardiology from Sanjiv entitled The Effect of Tafamidis on Cardiac Function in Patients with Transthyretin Amyloid Cardiomyopathy, a post-hoc analysis of the randomized Tafamidis in transthyretin cardiomyopathy clinical trial. So, Sanjiv, we're really looking forward to seeing the impact of this, what we thought was a very important paper. Can we start by, if you can just back up to the bigger picture and tell us about the pivotal trial for Tafamidis in TTR cardiac amyloid?
Well, it was abbreviated as the ATTR-ACT trial or ATTR-ACT trial, and it really was a landmark trial in the field of cardiac amyloidosis, specifically transthyretin cardiac amyloidosis. Prior to this trial, we really had no proven therapies for this condition, and the survival was pretty dismal. And so we really wanted to get a trial done that really could prove whether or not Tafamidis would improve the quality of life, exercise capacity, and most importantly, longevity of these patients and improve outcomes. And so this was a 10-year journey for many of us investigators. It started out with a small company called FoldRx, where they invented the drug. It's a transthyretin stabilizer, so it prevents the transthyretin protein from going from a tetramer and destabilizing into monomers, which is sort of the rate-limiting step for amyloid fibril formation in this disease. And so we embarked on this trial. It was eventually bought by Pfizer, who has sponsored the trial. And the trial really was an outcomes-driven trial. It had a hierarchical endpoint. And that endpoint was all-cause mortality and cardiovascular hospitalizations, a combination of the two. And the trial also examined 6-minute walk distance as a measure of exercise capacity, and KCCQ, or Kansas City Cardiomyopathy Questionnaire, which is a measure of health status. It kind of combines quality of life with symptoms and physical limitations. And so this trial was done at a time where there really wasn't some of the advanced imaging techniques we have to diagnose the disease, like technetium pyrophosphate scanning, bone scintigraphy. So all patients actually had to have biopsy-proven transthyretin cardiac amyloidosis. And the trial enrolled 441 patients who were randomized to either 80 milligrams of Tafamidis, 20 milligrams of Tafamidis, or a placebo. And what we found was that in that initial trial, that sure enough, Tafamidis did work. It did reduce hospitalizations, mortality, and markedly had an effect on 6-minute walk test and KCCQ. Now, it was not an improvement, but rather a delay in worsening. And so the patients on Tafamidis kind of were stabilized, just like the drug mechanism, and they didn't worsen, it seemed, for longer.
I think you'll agree that that trial and the very high profile in New England Journal primary paper, plus the growing availability of pyrophosphate imaging and other bone scintigraphy in Europe, has just led to an explosion of interest and people really looking for this entity, whereas 10 years ago, they did not as much.
Definitely. I think whenever there's a treatment for a disease, I think there becomes a lot more interest in being able to diagnose it, especially diagnosing it earlier. And one of the things that we can't prove from the trial, but does seem true, is that the earlier we start treatment with Tafamidis and other drugs like it, these TTR stabilizers, the better the patients will do. And that, coupled, as you say, with bone scintigraphy for the diagnosis, has really revolutionized the diagnosis and subsequent care of these patients.
Right. So as I recall, the patients who started off in New York Heart Class 1 and 2 did better than those who were in Class 3 at the time of randomization.
Yeah, and we think that definitely the earlier patients, now this was a post hoc analysis, but the earlier patients did seem to do better.
Okay, now with that as the background, tell us about the echo findings that are going to be published in JAMA Cardiology, which were so interesting.
Yeah, well, there's always this question of what exactly is the drug doing? And for any of these transthyretin cardiomyopathy drugs, and we're always looking for the heart because this is a disease really that impacts the myocardium, and we can see it on echocardiography. And so one of the benefits of this trial was that there were serial echoes done first at baseline and then serially in follow-up. So we had a lot of data to work with, and we could start to explore what effect the drug has. But the other interesting thing is we wanted to kind of first take a look at something as simple as ejection fraction. I think many people in the community, many cardiologists, heart failure specialists, and other physicians and healthcare providers tend to think of cardiac amyloidosis, transthyretin amyloidosis, as this sort of rare disease that is causing a restrictive cardiomyopathy where the ejection fraction is 65, 70%. In fact, one of the hypotheses as to why in heart failure with preserved EF or HFpEF trials that a lot of the drugs haven't worked at the higher ejection fractions is because all those patients, or many of those patients, have cardiac amyloidosis, or this transthyretin cardiac amyloidosis. Well, it turns out in this trial, when we stratify by ejection fraction, what we find is that only 50% of the patients had a truly preserved ejection fraction greater than 50%. And the rest had a mildly reduced or frankly, overtly reduced ejection fraction. I think that's so important because we can't forget the fact that there can be patients with an ejection fraction that's abnormal, so less than 50% and even less than 40%, that could have this disease. And in fact, as the disease progresses, the ejection fraction goes down. And that's exactly what we found, that patients in the lower ejection fraction do seem to do worse.
Honestly, although the echo findings you'll tell us about serially are incredibly interesting, that point I think will be very impactful for clinicians. You have to think about this, even if it's not kind of pure HFpEF.
Exactly. And I think that is really important because we don't want to miss this disease in patients with heart failure of any ejection fraction, especially because it's those patients with heart failure with mildly reduced and overtly reduced ejection fraction that we start on neurohormonal therapy that in many cases is sort of contraindicated in this patient population. They can do a lot worse, for example, on angiotensin receptor neprilysin inhibitors, sometimes on vasodilating beta blockers. So, I think that this is really important for clinicians to know. And it's also important to know that the treatment effect didn't vary based on ejection fraction. So when the patient is diagnosed, if the EF is low or mildly reduced or normal, the patient still gained benefit from Tafamidis.
Very, very important finding. Before we go on again to the echo data, the main echo data, was there anything about the mildly reduced or the reduced EF patients that would provide clues to a clinician? In other words, did they all have left ventricular hypertrophy or increased wall thickness, even if their EF was reduced?
Yeah, definitely these patients. It's interesting. We did a machine learning study to try to predict from just health claims data in the EHR, diagnostic codes. What are some diagnostic codes that tell you that the patient likely with heart failure likely has this syndrome? And the number one heart failure related diagnosis was combined systolic and diastolic heart failure. And that's because I think people understand that this is a patient population that has features of both. And they also have increased LV thickening. So when you have a patient who has left ventricular hypertrophy, who has sort of a mildly reduced ejection fraction, and also has increased wall thickness, you really start to think about this diagnosis. There's also the Mayo ATTR risk score, and that too, you got an extra point if your EF was less than 60, because these patients quickly, the EF starts to drop as the myocardium becomes more and more sick.
So that was one of the main points of interest in this paper. So now tell us about the serial echo findings that were reported.
Yeah, well, we looked at several different markers, and we really focused in on those markers that have been shown to be of prognostic value in the syndrome. And they tend to be in sort of three categories. One is the global longitudinal strain. So that's the marker of the subendocardial function, the longitudinal fiber function. Why is that important in this syndrome? Well, because the global longitudinal strain is really, because it's a subendocardium, that's where we think that the transthyretin amyloid fibrils go to first. And that's the first area of the myocardium to be affected by the disease. And in fact, when you see someone with a preserved ejection fraction, if they have this disease, it's because the circumferential and more so the radial fibers sort of take over. And in fact, what you see is you see no descent of the base, very little longitudinal function, and a lot of radial function in those patients with preserved EF. So global longitudinal strain, then filling pressure, so E to E prime ratio, and then the most important thing to the patient probably is their stroke volume. So that the stroke volume calculated by the left ventricular outflow tract velocity time integral, those were the major endpoints. And what we found is in all four of those, there was basically a halting of disease. The same thing we saw with a lot of the other endpoints in this trial. It's that the Tafamidis didn't necessarily reverse the disease, but it seemed to halt any progression, which I think is very, very important because the earlier we find these patients and diagnose them, if we can give them this drug and they don't worsen, that's really good because in all other forms of heart failure, we do see worsening unless they're on treatment, and so I think it's really a great finding, but also leaves open the door for other therapies that might truly reverse the disease and cause an improvement in these markers.
One of the things that struck me when I first saw the figure about the stroke volume and some of the other changes was that it looked almost exactly like the 6-minute walk and the KCCQ data in the figure in the New England Journal, almost the exact same change in the slope of progression. So I assume you think that they're probably related to those findings.
I do. Yeah. Sometimes we don't have a clear understanding of what exactly is improving a patient with heart failure, their condition. We may not see as much change in the heart, or it may not relate as well to the outcomes. But I do think in this situation here, we do see that really the separation between the curves happened between month 6 and month 18. And that's really when we saw the improvements in clinical outcomes as well. It was interesting that 6-minute walk distance and the KCCQ separated earlier. And where we see that earlier separation is in E to E prime velocity. And so it may be that first, because potentially inflammation goes down, the less you have all these monomers circulating around in blood, inflammation goes down, there's less congestion, so E to E prime separates. And then later on, you get the actual effect on the myocardium itself. And that may have to do with the overall global longitudinal strain and stroke volume.
That's so interesting. In many situations like this, so there's several small publications, just uncontrolled data about the effect of tafamidis on echo parameters. But I think something else that really distinguished this paper that you did was the controlled aspect of it coming from a pivotal trial, the blinded read in a core lab, and the duration. That in particular, I think, really struck me. I mean, was really 2.5 years, right? That's much longer than any other information we have about effect of tafamidis.
Yeah, I think that was a real strength. And you can't discount the multi-center and placebo-controlled, like you said. I mean, I think that these uncontrolled studies that are open label, single center, they're very important because they give us a hint, but they're certainly not proof. This is probably the best we're going to get because this is, although it's post hoc and so exploratory in nature, it really was from a gold standard randomized clinical trial. And it's really the benchmark by which every other trial has really tried to follow. And so we do see this type of analysis being done in other ongoing and previously completed transthyretin trials. In fact, there was one from the Apollo trial, which was strictly for neuropathy, but they had a cardiac subgroup, which they defined as having left ventricular hypertrophy without having a history of hypertension or significant hypertension. And although that was also a post hoc analysis and one that, I think could have been skewed a bit based on how they included the cardiac patients. There was no nuclear scintigraphy at that time. It did kind of show the similar findings. What was interesting about that trial was that those patients with hereditary transthyretin amyloidosis who had evidence of potential cardiac involvement were much younger, much less sick. You would think that they would have more reversible disease. So the fact that we're seeing it here with tafamidis delaying progression, I think is really important because these patients are a lot more characteristic, of course, of the patients we see with true cardiac transthyretin amyloidosis who are older and a lot sicker.
Yeah, it's very generalizable. You and your group have been interested, I know, in echo measures of left atrial size and function and performance. Does that need to be collected prospectively in a certain way to get rigorous data, or can that in some way be extracted from this amazing echo data set?
Well, it certainly can be extracted post hoc, if we have access to the echocardiograms. And in this particular study, the echocardiograms were evaluated by a central core lab, but it was a commercial core lab where they only had left atrial diameter. And so we're at a bit of a loss. We reported that data, but we know that left atrial diameter is really inferior to left atrial biplane volume assessment, even single plane volume assessment. And so one of the things we've been talking about with sponsors is they really need to make sure that they have control of the echocardiographic images, especially in today's day and age where we have AI algorithms that can automate the measurement of left atrial volumes, left atrial strain. They're getting better and better. And even if a group, say, wants to look at the echocardiograms and isn't expert on left atrial strain, just left atrial maximal and minimal volume, by which we can then calculate the left atrial emptying fraction, is extremely important because that left atrial emptying fraction is akin to left atrial reservoir strain, the ability of the left atrium to fill during left ventricular systole. And that is such an important marker. So there's a lot more that can be done. And I sort of think, just like E to E prime, the first beneficial effect we're going to see is in left atrial reservoir strain or left atrial emptying fraction with these drugs. And so I think that as more and more potential therapies come out in earlier phase trials, the left atrial function could be an early barometer in a phase 2 trial, for example, that could give credence to going on to a pivotal trial.
Interesting. It's also a really good lesson about these data are such a precious, precious resource that's been so much effort by the patients that it really has to be made available to investigators to really get as much information as possible.
Yeah, and there's a lot of hidden information in these echocardiograms as well. So I look forward to a day where part of the data set, database lock at the end of the trial, is all the imaging, not just the echocardiograms, but the ECGs, and if other imaging is done, that all of that is part of a locked data set that then can be analyzed using just the AI and machine learning techniques are advancing so rapidly. I think it behooves all of us, especially as academic investigators that are working with sponsors, that we really, really need that data. The data needs to be open to investigators to analyze. And I really think we owe it to the patients to be able to do as much as we can with the data.
Absolutely agree. And then finally, maybe if you can give us a glimpse into the near future. So recently, the FDA looked at patisiran, and then coming up, I think, is acoramidis. Can you give us a little flavor of what's going to happen? And do you think that we will see a time when there's some reversal instead of delayed worsening?
Yeah, I do think that we're going to see reversal. I hope we are. First of all, the acoramidis trial results, the attribute CM were really, I think, important because that provides another stabilizer that can compete with tafamidis. One thing that really we struggle with is the exorbitant cost of tafamidis, so we're hoping that the costs come down. And in some ways, although there was not a head-to-head competition or a comparison, I should say, between tafamidis and acoramidis, I think that there were, my clinical experience and also the trial, acoramidis may be more effective. We might see some reversal. But I think that the next group of drugs, the silencer drugs, they're sort of called, whether it's an RNA interference drug or if it's an antisense oligonucleotide, so patisiran, Udelson, and they're sort of newer versions of these drugs. These are all in trials specifically in cardiac amyloidosis, and I'm hoping that that will lead to approval in those patients. But again, cost will be an issue. I think the best likelihood for true reversal is going to come from either CRISPR-Cas9 gene editing or the depleter trials that are ongoing right now. So with gene editing, it's also a TTR silencer, meaning all of these silencer drugs go to the liver and they turn off production of transthyretin from the liver, which is the primary source of transthyretin. But the gene editing, we think, based on the trials that have been done so far, inhibit to greater than 95%. And in other amyloid diseases, when you get that much inhibition of protein production, you start to see reversal. Now, in clinical practice, the other silencers are about 80 to 85% what we call knockdown or inhibition of the production. And so we might see it with these CRISPR-Cas9 therapeutics. But I think that even more promising than that are the depleter drugs. Now, we still have to see, it's all in early to mid-phase clinical trials. And so these are drugs that are antibodies that go after the fibrils themselves in the heart and recruit the immune system to try to deplete the heart of amyloid fibrils. So we'll see if that can reverse the disease as well. There's a thought that if you simply reduce the concentration of transthyretin monomers in the circulation, like with Tafamidis, that the transthyretin should seep out of the heart. But we really haven't seen that with some of the drugs so far. So there's a lot still that we need to learn, but the future looks bright for these patients with transthyretin cardiomyopathy.
Thanks so much. I think your paper will be really high profile and make a big impact on the field, and we'll really look forward to having people see it. I'm Jim Udelson. I've been speaking with Sanjiv Shah about his article just published in JAMA Cardiology entitled Effect of Tafamidis on Cardiac Function in TTR Cardiac Amyloid. You can find a link to the paper in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks very much for listening.